So I want to give you a little history on what we've done with IORT. I know there's a lot of talk out there about IORT having no reimbursement or not getting paid at all. But in fact, we do get paid for IORT, and there's actually very good payment for IORT, and we're moving that forward. So let me kind of take you back a couple of years and tell you where we came from first, just to get you started. Prior to 2011, we used to use a variety of codes to report IORT procedures. There were not specific procedure codes to report what we were doing, so we used some miscellaneous codes. There wasn't good reimbursement tied to those miscellaneous codes. Nobody likes to report miscellaneous codes because it requires a lot of additional paper. So there wasn't a lot of history. Today there's not a lot of history for payers to look at what's been done with IORT. ASTRO and the college both supported moving forward with permanent IORT codes. And these are codes that specifically describe what we're doing for IORT. So in January 2012, we got our new codes. And you can see those here. I've listed them here. And we've got two new codes for IORT treatment delivery, and we've got a new code that the radiation oncologists are reporting for treatment management for IORT. So now we've got pretty good coding for those two folks that are part of the procedure, but we're still working on the surgeon side, and that's important to us as well. What happened, though, is once these codes were developed in 2012 and came out, CMS, in their infinite wisdom, decided to package those codes because it had intraoperative in the title or the description of the code, so they figured it was an ancillary intraoperative service. So they packaged it and didn't give hospitals an additional payment when IORT was added in the OR. So we developed what we called an IORT coalition. We pulled together all the manufacturers, some of the key thought leaders, hospital administrators, surgeons, radiation oncologists, and physicists into a group, and we called it our IORT coalition. And through this coalition, we sat down with CMS, we made presentations to the APC panel, which kind of governs the outpatient process for Medicare. And we explained that if these patients went for radiation therapy and any alternative option, CMS would pay separately for it. Why wouldn't they pay for it separately if we did it in the OR? We also explained that IORT was not an ancillary service. So it wasn't something they should really package and fit the description of guidance procedures or other procedures like that they did package together. CMS listened to us, and in July 2012, they came out with a proposed rule. And again, as intelligent as they are, said, we'll pay you for it, but we're going to give you about $400 for it, because that's what we figured it's worth. Again, no claims history and no data in the system for them to come up with a really good number for us. So they gave us this $400 number. Again, the coalition threw their arms up and said, we're not just going to sit still and let CMS do this to us. We're going to go back. We researched actual cost data from about 9 hospitals across the country, and we sat down again with CMS, and we showed them this is what it actually cost to keep the patient in the OR the additional time and provide IORT. And they listed again. However, they still don't have really good data, and those of you who bill Medicare know they never pay you what it really costs you to do something anyway. So they weren't going to pay us what we asked them for, but they did increase the payment amount in the proposed rule to about $950, and then in the final rule when it came out, it was about almost $1,000. And based on wage indexes, because nobody ever gets paid the actual national value of $978, there's always a wage index that goes into effect based on where you live geographically. So $388 if you're in Puerto Rico, up to $1,700 with that geographic factor worked in. So not bad reimbursement just for those new codes. Remember, that's just one code for IORT, the new treatment delivery code. So to continue on what we're doing, we look at this today, and we're here where we're standing right now, and we're saying, are the hospitals getting paid appropriately? Are the physicians who are involved getting paid appropriately? And in our opinion, in the coalition's opinion, we still have some work here. So on the facility side, we're going to continue to work with hospitals to collect their data and put it on their claims correctly, so CMS does have some good data in order to base future payment. And if you have knowledge about the hospital outpatient program, CMS uses the information they get on claims from hospitals to set payment rates. So if hospitals aren't reporting information correctly or accurately on their claims, then they're not going to get paid correctly in the future. So we're working with hospitals to try to elevate that 978 national value up a little higher, more appropriate for IMRT. We're also working on the surgeon side. There's a couple of different codes that are reported right now for the applicator placement and removal in the OR, and it's only breast specific. So if you're doing IORT for any other indication or any other body site, there are no codes to report. So we're working closely with the college, again, to help develop some codes for placement and removal of the applicator in the OR for all body sites, not just breast. So we're going to continue to do that, and what I would ask of all of you, if you are interested in moving forward with your IORT program, make that known to your professional societies. When IORT comes up as a discussion or CPT comes up as a discussion item, make it known that you're not paid for certain things, including IORT, and that additional time that you spend in the OR with the patient. On the radiation oncology side, we did get an appropriate code for treatment management, so the radiation oncologists are now getting incremental reimbursement when they're involved in the OR as well. So if we just kind of take a look at what that means in terms of dollars, and again, national values, the hospital's incremental revenue to add IORT to a lumpectomy case is about $7,500. So the hospital isn't doing bad when IORT is added in the OR, and they're getting this amount of money now. So keep that in mind when the hospital tells you that you can't start your program because they're not getting paid for it. They are getting paid for it. I'll give you an email address and you can let us know, and we'll be happy to talk to your hospital administrator and explain they are getting paid for it. The surgeon right now is only getting about $100 incremental revenue for placing and removing the applicator, and the radiation oncologist about $1,000 for their time in the OR, and that includes the physicist as well. And this is not just the new treatment management code. This is all of the professional components of all the physics codes, the dosimetry, any simulation, and physics consults that they're providing for these patients. Excuse me. So a couple of things that are really important starting up a new IORT program, or you're already part of a program. Keep in mind that many payers have different coverage policies. Two really key things. Managed care is probably one of the hurdles that's easiest to overcome if you're very proactive. If you're starting a new IORT program, go to your managed care department, the hospital, talk to whoever does your managed care contracting in the office, have them pull your contracts. The first thing to do is make sure the new codes are included, because if they're not, the payer's not going to add them if you don't ask them to. They're never going to look at a claim form and say, gee, this provider's billing new codes, we better add them to our negotiated fee schedule. Never happens. If it does, I'd love to know about that one. So make sure that these codes are added. Make sure that you contact your managed care providers proactively. If pre-certification is required, which it is for most of your surgical cases, it probably is for IORT as well. So make sure that you go through your pre-certification process, not just for the lumpectomy or the procedure you're doing in the OR now, the surgical procedure, but make sure you're pre-certing the IORT procedure as well. You have to get pre-certification for both of those. Again, if you need support with that, I'm going to give you some contact information. We're happy to support your office or your hospital with some of these functions. So the future of IORT, I don't know that I have to dwell on this any more than the clinical folks have done that, but from a reimbursement perspective, payers are really looking at a couple of different things. Their economic goals are to reduce costs. The more options that you have available to you, the more likely it is that you'll find something that fits with the payer and the patient. So make sure that you understand that IORT really adds great value to what payers are looking at. It's another option. It's a lower cost option to 7 weeks of radiation therapy. It's certainly a lower cost option than IMRT for many payers. It's also pretty easy on the patient too, to come in, have their surgery, have their radiation, and go. And I don't need to tell you guys that. Obamacare's initiatives are also more bundling, more packaging. Let's pull things together. Let's give you a lump sum payment for providing care to a patient. And you do what you want with that lump sum payment. If that's the way you're going, you really need more options available to treat all of your patients. IORT expands your options. So it really, in summary here, and I'm going to make it brief, it provides benefits to everyone. The patient can get back to work quicker. It addresses those bundling initiatives that Obama has made known that he wants payers to look at or Medicare to look at. It supports a lot of quality care initiatives that payers have, lower cost options or lower cost alternative treatments for patients. And it improves patient access. If the patient can't come back and forth for 7 weeks or even a week in some cases, here's an option for those patients. So it's a great option for everyone involved. So let me give you that important information. This is how to contact us. If you are Zoff customers, we make available what we call a hotline. And this can help you out if you need pre-certification for your patients, if you're having trouble negotiating your managed care agreements and you want to talk to somebody about putting your cost analysis together to get to the payers, or getting on the phone with them and helping negotiate. If you're underpaid for your service, if you think a payer has short paid you, or CMS has short paid for something, or denied something that they should have paid for, please give us a call and we're happy to help you with that. We have a toll-free line. We have an email address that's specific, zoft@thepinnaclehealthgroup.com. You can email questions if you don't want to pick up the phone and call, or you can send us a fax as well. All HIPAA compliant. We ask that you don't send patient information, however, but if we do need to share patient information back and forth, we're happy to do that through our HIPAA compliant line. So with that, I'm going to close it up, and I think we're opening up for a panel discussion here with questions. Thank you.